Hello, and welcome to the series Effective Management of Patients with Lung Tumors in the COVID-19 Era. This is the first module of a 6-week series and is an expert roundtable. Today's session is approved for 1 hour of CME, CNE, CPE, and AAPA credit. The series is provided by the North American Center for Continuing Medical Education and HMP Company and is supported by educational grants from Merck and Pfizer. My name is Corey Langer. I'll be the moderator for today's program. I'm the Director of Thoracic Oncology, the Abramson Cancer Center, and Professor of Medicine at the Perelman School of Medicine, the University of Pennsylvania in Philadelphia. And I'm joined by Dr. Michael Angarone, Infectious Disease Specialist, Northwestern University, Feinberg School of Medicine in Chicago. Dr. Angarone.
Hi, thank you for having me. Nice to be here.
Also by Dr. Marina Garassino, Medical Consultant, Thoracic Oncology, Med-Onc Division at the NCI, the National Cancer Institute of Milan, in Milan, Italy, who's been in the thick of it. Dr. Garassino.
Hello, everyone.
Dr. Andrew Haas, Director of the Section of Interventional Pulmonology and Thoracic Oncology, Bronchoscopy Director at the University of Pennsylvania. He's also Associate Professor of Medicine at the Perelman School of Medicine here in Philadelphia. Dr. Haas.
Hello. Thank you all for joining us today and giving me the opportunity to speak.
And finally, Dr. Roy Herbst, the Ensign Professor of Medicine, Medical Oncology, and Professor of Pharmacology at Yale, Chief of Medical Oncology at the Yale Cancer Center and Smilow Cancer Hospital, and Associate Cancer Center Director for Translational Research at Yale in New Haven, Connecticut. Dr. Herbst?
Yeah, thanks, Corey. Great to be here with all of you.
Thank you. So we're going to, in the next hour or so, we're going to cover a number of topics, the recent developments in the epidemiology, pathology, and current treatment approaches for COVID-19. How has the pandemic altered standard practice? And what are we doing about standard practice in the face of the pandemic? The impact on research in thoracic oncology, the precautions we need to take on patients who are about to undergo procedures, whether or not there should be universal antibody and antigen testing essentially on all admissions or individuals who are about to go to the OR or undergo procedures like bronchoscopies. And finally, the effect on patients if they get infected by COVID-19. We're specifically focusing on lung cancer patients, but does it differ by age or comorbidity, by modality of therapy of country or area of the world? And finally, are patients on TKIs less vulnerable than those receiving either chemo or immune checkpoint inhibitors? So, Dr. Angarone, we're going to start off with you, and the rest of us will weigh in periodically, but if you could just give us the basics, the epidemiology path and current treatment approaches as an ID specialist.
Sure. Yeah, and I think all of us have really, been hit hard by the SARS coronavirus 2 pandemic and the impact that infection with this virus has had on all of our patients, cancer patients, non-cancer patients. When we look at what's been going on with the SARS coronavirus 2 pandemic, all areas of the world have been affected. Obviously, China, South Korea, Italy kind of hit harder first, and then that was followed by the United States. And in the United States, we've obviously seen a huge number of patients affected by this virus that have been hospitalized and that have died from this virus, and the impact that it's had on the healthcare system, not seeing patients, holding chemo, the stoppage of research trials. I think what's been interesting is that as we've progressed through the pandemic, so over the past 3.5 months, we've started to see the evolution of the virus and our approach to this virus. So we saw kind of those steep curves early on outside of the United States, in the United States. And then when we started to implement a lot of our shelter in place, wearing masks, trying to test as many patients as we can, we started to flatten that curve. And so we really started to see a flattening and an evening out of the number of cases that we were seeing day to day. And now we actually have states in the United States that have seen less numbers of cases from day to day. Illinois is one of them, New York, Fortunately, we've been seeing less cases day to day, and their curve is kind of on the downslope with their number of cases. Same thing throughout the rest of the world. So countries in Asia, they've been seeing less and less cases day to day, but it's still here. We obviously worry that there's going to be a second peak to this virus, and we're going to see more people get infected. When we think about cancer patients and our patients with lung cancers, they've actually been hit just as hard as everyone else. It's hard to kind of look at the data to see how many patients. Some of the reports coming out of China have actually shown that patients with cancers, and in particular lung cancers, interestingly enough, the incidence was slightly higher than that in the general population. I think there was one study that showed the incidence was about twice as high as what was seen in the general population. And cancer patients in general, in China specifically, and some other areas of the world, have been hit hard in terms of higher mortality rates, and the cancer itself being one of those risk factors for more severe disease and for mortality related to this infection. With treatment, I think one of the best things is that we're starting to get data from some of these randomized trials looking at the different treatments we have. We have remdesivir, which is an antiviral that has now been shown to lessen the illness, so the length of the illness, and that's statistically significantly different from placebo. We've had reports of some of these IL-6 inhibitors and these modifiers of an inflammation impacting patients in a beneficial way. There was a report recently from the recovery trial that's out of England showing that dexamethasone for individuals with more severe lung disease may actually impact those individuals in a beneficial way and actually show a decrease in mortality compared to usual care. So we're starting to see some of the treatments that we've all been looking at that might work. There's been no panacea, so we don't have the penicillin yet for coronavirus, whether or not you believe penicillin still is an effective antibiotic. But we're still looking, and we're looking at the appropriate therapies. Convalescent sera, I think, is the other approach that we're all really looking to see how that's going to impact our patients. I know here at Northwestern, we've given quite a few patients convalescent sera on study, as well as remdesivir and some of the IL-6 inhibitors. And I think that's kind of the broad overview of where coronavirus is right now. I think we're still working through the pandemic. We're still seeing cases. We've, I think, gotten better at the supportive care of these patients. And I think some of the members on the panel can probably speak to this as well, of how well we've gotten at handling the more moderate to severe pneumonia, the ARDS, the inflammatory syndrome that these individuals have gotten, even without a specific therapy for coronavirus itself.
Andy, can you weigh in, please, particularly in the management of the sicker patients who've ended up in the hospital, and particularly the ICU, some of the interventions that have proven successful, whether any specific interventions work better in lung cancer patients? And my impression that, at least amongst my population, they've been sheltering in place, and very few of them, fortunately, have actually developed it. But and also, both of you, any formal studies on convalescent sera yet that have verified its potential, or are they still ongoing? So Andy first, and then Dr. Angarone.
Sure. So having spent time wearing my other hat, doing critical care during this period of time, it was unique compared to what we normally see in critical care. Many of these patients, while some of them did acutely decompensate, requiring intubation and ventilatory support, many of them smoldered along for many days with just slowly progressive hypoxemic respiratory failure, ultimately around day 5, 7, 8 or so requiring intubation. So during that period of time, initially there were thoughts to intubate these patients early, and then we began to take approaches that were being adopted in Italy, whereby using helmets that essentially provide a BiPAP as well as a containment mechanism to prevent dissemination was very effective. And so we started to implement that. And while no randomized studies showing it, we certainly saw patients that we feared would end up being intubated that could be salvaged from intubation using these helmets that they would wear. And then in addition, if patients did fail and end up intubated, they took very rapid decompensation, very severe hypoxemic respiratory failure, many of them proceeding into renal failure, multisystem organ failure. The one intervention that seemed to help the most was proning, so turning the patients from supine onto their abdomen to redistribute blood flow to the less involved areas of the lung, did have impacts on oxygenation. And ultimately, I think, based on other studies, probably affected mortality as well. They had many of these patients also had a very unique pattern where they would get better, and then 3 to 5 days later, they get worse again. So there was this very unique waxing and waning of improvement and a decompensation and improvement and decompensation. So the evolution and phenotype of this disease was very different than what we would see in other critical care settings.
Hypercoagulation has also been identified as a major sequela. Are patients routinely getting anticoagulated, or is that done on a case-by-case basis?
So we had made sure patients got at a minimum, the usual prophylaxis for DVT. However, as this information about the coagulopathy and microvascular injury became more evident, we started kind of doing a mid-level, not full anticoagulation, but not just prophylaxis. It was kind of a mid-level of anticoagulation for these patients to minimize that risk. The thought being that maybe a lot of the renal failure they were developing and other systemic liver injury and maybe even neurologic injuries were mediated by this microvascular injury and thrombotic process that seems unique to this disease.
Mike, any word on the convalescent sera trials or some of the ongoing efforts? I think we're all familiar with the remdesivir trial that you alluded to that certainly seemed to accelerate some recovery, and there was a non-significant reduction in mortality. So it certainly seems to be part of the regimen. I assume, is that standardly given to all the patients that come in?
Yeah, so remdesivir, the randomized trial really showed that there's a benefit in that recovery from illness. Numerically different mortality, but not statistically different. So many hospitals in the U.S. Were put on the EUA, so the emergency use authorization by the FDA to use remdesivir. And so we were offering it to patients on a regular basis outside of the trial. If they wanted to go in the trial, we could. The second phase at Northwestern, our team is participating in the remdesivir, the ACT trial. The second phase is with a JAK inhibitor with the remdesivir. But remdesivir has been used for patients who want it. The IL-6 inhibitors, so tocilizumab and cerulumab, have been used. The convalescent sera, I think, is an interesting one because that's been looked at for other viral infections, other inflammatory conditions, just like IVIG or immune modification with immune globulin. And we've been giving convalescent sera to patients. There's ongoing studies. So I know there's large studies looking at convalescent sera and its benefit in patients who just get it, and they're trying to compare it to usual care patients. And there's a few studies that are trying to do placebo-controlled convalescent sera. So hopefully we'll get those results to see how impactful those are, because the one thing that we will have is a large group of people who've been infected with this virus, who, if the convalescent sera is shown to be useful, we can call on them to donate their plasma so that we can use that for an effective therapy. And so we're all really interested to see what the data is going to show, and what the data is going to show from, I think, well-designed trials, because there has been a lot of anecdote with coronavirus, and all of us have kind of changed our practice over the past few months. But as we get better and better, I think Dr. Haas mentioned this, the early intubation and then fading more to the later intubation, the prophylactic anticoagulation to then more of kind of a, not quite full anticoagulation, but kind of a moderate dose. And now using the antivirals like remdesivir or convalescent sera as we get more data.
So Andy, what is our standard approach systemically to these patients? Are they just routinely started on all of these agents? And also, second part, you uniquely wear two hats, involved in the pulmonary and thoracic oncology as an interventionalist, but also as a ICU specialist. Is there anything unique about the potential intersection or interaction of COVID-19 and specifically lung cancer? So if you can address the first question regarding the systemic management, which agents are they receiving routinely, and then the second as well. And then I'm turned to Dr. Garassino.
Yeah, so we've been routinely now using remdesivir in those patients who come in with hypoxemic respiratory failure. It should be noted that the study that showed the benefit was non-intubated patients. And so we don't know yet whether there is a benefit in patients that have progressed to complete hypoxemic respiratory failure and require intubation. Those studies are ongoing. Nonetheless, given that there has been that benefit shown, we are participating in that study to try to demonstrate whether the remdesivir in intubated patients will make a benefit. So we also have the convalescent sera study open at our centers. So we are really trying to be, I guess, as academic about answering the question as to what will benefit and not benefit the patients. So all the patients that end up in the ICU with us are offered one of these clinical trials to enter, depending on their failure and other exclusion criteria. We try to pick the best study that may be for them. If they don't qualify, then we generally just go for standard of care management for these patients.
It seems like hydroxychloroquine and some of the other, I guess you could say, collagen and vascular medications haven't really worked out too well, have they?
Correct. So we very early on were on that boat, but as the data became available, the ship has sailed. So,
and that's true as well for you, Mike. I think you're on mute. Mike, unmute yourself. Yeah.
Yes, yeah. For us as well, I think we've started out, using a lot of the therapies that were talked about and and the experience that other clinicians had. And I think as information came out that they weren't as valuable, we changed our practice, which I think is good. That's what you want. That's, you're going for, this is what we think is going to work, and you find out it doesn't, and then you change your practice to something else that does. And I think it's actually been more to the advantage of our patients than the disadvantage, is that we have been changing our practice.
As thoracic oncology specialists, we're used to studies that take many months, even years to complete. And here we're talking about completing studies literally within a week or two or a month or two in real time. And it's absolutely essential given the gravity of the illness. Anything unique, Mike, about the intersection between lung cancer and COVID-19?
So, the biggest thing I think, well, one, obviously the lung, and you can develop from SARS coronavirus infection, you can develop a pneumonia. And so whether that dysfunction in the lung cancer patients is going to make that pneumonia worse or more difficult to treat remains to be seen. But obviously that's what we're worried about. There are some of the epidemiologic studies from China. So in a couple of the larger cancer centers, that did show that individuals with non-small cell lung cancer, I believe, were at higher risk for developing infection, and were at higher risk of morbidity and mortality related to that infection compared to the general population. Now, when you mix that with other cancer patients, it's hard to know where the lung cancer patients fall, because as you mix more of the cancer patients in with chemotherapy and with other therapies, it probably balances out. But we do worry about the lung cancer patients because just the nature of their illness. And I think to your point, a lot of those patients, I think early on, knew to stay away from people, and did, at least here at Northwestern in Chicago, did a really good job of isolating themselves and quarantining themselves from others so that they wouldn't get infected.
Marina, you've been in the thick of it. After China, Italy, and particularly your section of Italy was hit the hardest. And truly, the hospital system was overwhelmed. I remember talking to you at the very beginning, and the care and stress was absolutely obvious on your face. You look a lot more relaxed now, thank God. But you've been one of the principal investigators of the TerraVolt trial, and again, enumerating the interaction between lung cancer and COVID. Can you elaborate on what Mike has talked about?
Yeah, so I think that the numbers of COVID-19 and lung cancer seem to be different from the other cancers, because in ASCO teravolt and also CCC19 were presented, and the mortality for all types of cancer were about 13% compared to 35% for lung cancer. So I think that there is something behind lung cancer, which is also for the hematological malignancies, they are at higher risk of mortality compared to the other cancers. Clearly, we don't know if this is related to the type of cancer or it is related to the co-presence of comorbidities and older age for this kind of tumor or other alterations, but it is true, and it comes from China and also from teravolt, that the mortality is higher compared to the other tumors. So I think that we don't know how to reduce this mortality. In particular, the first results of teravolt suggested that the majority of patients coming from the European system, so during the surge, during an overwhelming situation, suggested that the majority of patients did not have access to the ICU beds. So the majority, only 5 patients among 200 were ventilated, so just a minority. We are very curious to see if this is just a European phenomenon or it is a global phenomenon, and also if there is a prejudice behind this, or is just because there was the surge. But in some countries where the system was not so overwhelmed, the rate of ICU admission was the same as in Italy, in Spain, and in France, where we were totally overwhelmed. So I think that still the protection of these patients is very important, because 35% of risk of death is very high for this kind of patients, that they have in 2020, they have a very good possibility to survive for years. What we do in Italy, and in particular in my cancer center, we try to educate the patients to be protected, to wear masks, to quarantine, because if they get COVID, I think that they are really in trouble. The other results that I think that are very important for lung cancer, coming again from teravolt, are about the treatments. What we saw is that in the beginning, I was very scared about immunotherapy, because 2 patients of mine died on immunotherapy, but the results of the teravolt suggested that immunotherapy is not at higher risk of mortality, but potentially chemotherapy is at higher risk of mortality, and also the regimens with chemotherapy and immunotherapy. And it seems that patients on tyrosine kinase inhibitors have less risk of mortality compared to the others. But again, we don't know if this is a problem of the therapy, or it is just because they are mainly never smokers and they have less comorbidities. So I think that maybe in the future, the protection remains fundamental, and maybe also we have to create some programs if the patients are on chemo or if the patients are on TKI, and maybe if you see that you are in a decrease of the incidence of COVID-19, maybe you can be also more flexible than when you are in the surge of the pandemic. So I think that it's impossible to give a recipe for everyone. I think that we have to personalize the protection, we have to personalize the treatments, and I think that we have to speak with the patients for a long time to do a very careful shared decision making, and to decide case by case according with the risk, with the comorbidities, and with the treatments, and to balance the risks and the benefit. Another big problem that I think that it's not only in Italy, but everywhere is the problem of the screenings. We stopped immediately the screenings in March for breast cancer, for colon cancer, and also for lung cancer. And I think that we must be very careful. Maybe we have to find a more safe solution to, again, to continue to screen the patients. Otherwise, maybe in 2021, we can see a wave of more advanced thoracic cancers in the future. So basically, I don't have a recipe. I just say that thoracic cancers are, in my opinion, at higher risk of death compared to the other tumors, and we must be very careful with chemotherapy.
Roy and Yale, and I know you two, as New York City had experienced, saw a surge in cases with many patients in the ICU. How is that? How has COVID-19 altered standard thoracic practice? Did you make any allowances for how to manage patients? And I want to separate that out from the research studies. I want to focus specifically on standard of care.
Oh, absolutely. I think we actually heard it from Italy first, or from other countries, that to separate your COVID and non-COVID patients. So we actually in New Haven moved our entire clinic out of our main hospital building, 7 miles away to North Haven, so that we could create an environment where we had, very few, if any, patients with COVID. I agree with you, Corey. The patients seem to hunker down, and we haven't seen too many lung cancer patients, thank goodness. But it has altered our practice a number of ways. Of course, the volume has been much down because we've not had very many patients being screened, not had many bronchoscopies and CT scans being done. But for those that we see many with telehealth now. So that's been a new thing, and actually something I think we'll keep doing. It's sort of hard to do that for new patient visits. So we are seeing new patients, but then we're thinking carefully about how we treat them, and they're being treated differently. I mean, we were a place that would try to put everyone on protocol, as I'm sure your center strove for that as well. I haven't put someone on protocol in 3 months. We actually, our hospital at peak had about 460 patients with COVID in-house. It's a lot for New Haven, with as many as 120 in the unit. So we were hit pretty hard, being close to New York. So we're first now getting back to bringing back enough staff. That's another thing. You can't even run the protocols if you don't have the staff in the hospital, given the social distancing. But we're starting to run protocols again. But we've done a couple of things to try to distance out visits. Very coincidentally, pembrolizumab got a 6-week approval, just as all this was going on. We were actually doing it anyhow, but we started doing that. We were getting very conservative with chemotherapy, a lot of it based on the data from the TerraVolt and the other databases showing that patients with chemotherapy did worse. So a number of times I treated 1% PD-L1 patients with immunotherapy alone, where I probably would not have done that, pre-COVID. And then, of course, as we got more comfortable, we've added in chemotherapy. But I must say, I'm very proud that we did get new patients in. There are several patients that fled New York that came here, with needing emergent radiation therapy, needing diagnosis and pathology, and we treated with as many oral agents as we could. The lung map trial, with a lot of oral agents, is one thing that I kept open till the very end. Certainly, we've been using a lot of EGFR inhibitor, but life's beginning to come back to normal, but it's slow. And I do worry, as the others mentioned, about people who are not going to get diagnosed and the long-term consequences of that. We also worry about lung cancer patients with COVID, because some of them are on the immunotherapy. I guess we'll talk about that. And also the pulmonary consequences of the disease, should they get it, and the impact of that on further therapy. But we've learned a lot. I did a program with Dr. Garassino very early on, about 2.5 months ago, and that was like enormous learning, because we were a couple months behind, and I fear other states in the United States, like Houston, are going to be are going to be there in a few days too.
Mike, you alluded to the fact that in many places, Illinois and New York, and I'm pleased to say New Jersey and Pennsylvania as well, we seem to have had our surge, and it seems to be going down, at least in numbers, but particularly in the South and parts of the West, I don't think they've completed their initial wave. the numbers unfortunately are going up, and it seems to be inversely proportional to physical distancing. Andy, how can you spotlight some of the numbers in our hospital system? We're actually 6 separate hospitals. What were we at the peak? Where are we now? And I want to address, before I get back to systemic therapy of lung cancer, special precautions that we are taking now.
So the peak that we hit in Philadelphia and the greater Philadelphia area was certainly nowhere near what they experienced in Italy, and even less than New York and New Haven. So at its peak, we were roughly probably around 250 to 300 patients in our 3 center city hospitals, probably around 75 of those patients being on mechanical ventilation. I think the state instituted social distancing in a timely fashion, and that's what allowed our peak in our surge to not be as large as it was in some other centers in some other areas of the world. We now, over the course of the last several weeks, are down to roughly 40 patients in the hospital, and maybe about 15 of those patients intubated in our center city hospitals. So the surge is definitely over. We're at the lower end of the curve, and hope to stay there and not to have another surge. So what we do now in terms of precautions, so as you can imagine, when this all started, at least from a bronchoscopy perspective, which is kind of my specific interest, we're very concerned about performing procedures on patients, given that this is obviously a respiratory transmitted virus. And one of the early reports out of China that a patient undergoing sinus surgery basically infected the entire operating room staff and operating room area of up to 15 patients, I should say staff, that were infected as a result of that procedure. So I advocated actually very early to do testing on patients before coming in for their bronchoscopy. However, due to resource allocation and lack of resources, we could not perform that testing, at least initially. So ultimately, it was maximizing PPE, making sure all staff, regardless of patient symptoms, would be wearing full PPE for the procedure. And as time passed and testing became more available, we then started to institute doing tests with every bronchoscopy. So patients that come in now have to have a test within 72 hours of having a procedure done. And if they're negative, we can proceed. If you look at our volumes, we generally do roughly 8 bronchoscopies a day. And we were down to 1 to 2 bronchoscopies a day during the time period of the surge. I think, as Roy and others had mentioned, patients were hunkered down and sheltering and were not coming out. And so our volume went down. We're now up to about 5 to 6. And really in the last 2 weeks, again, getting back to that reflection that patients were not coming out, they weren't getting their screening scans or follow-up imaging. We now are seeing our surge in patients with their nodules, masses, tumors growing, and so on. And so I think now we're starting to see the pickup of the delays in care that potentially were not intentionally happening, but happening as a result of the concerns about viral spread.
Andy, are we routinely testing everyone now before any procedure?
Correct. So any procedure, any operating room procedure, whether it's bronchoscopy or any other procedure, is undergoing testing within 72 hours of the procedure. And then during that window of time, if they happen to have 72 hours versus 24, they're asked to quarantine in their home so that they do not get exposed after being tested and potentially then disseminate the virus. So yes.
Are we also checking blood-based antibodies, or not routinely yet?
No, so Penn has a study undergoing for healthcare providers where every 2 weeks, healthcare providers can get a blood test looking for antibodies. However, there is no standard for that for patients at this time.
Mike, if you can unmute yourself, what is the standard approach now in Chicago, and particularly in Northwestern, for procedures? And what's your advice at this point in terms of protecting patients and protecting the healthcare workers from the infection?
Yeah, so we're doing pretty similar to what is being done at Penn. So anyone who's coming in for a procedure, bronchoscopy, surgical procedure, endoscopy, they're getting tested, and we're trying to do the test 48 hours before the procedure. Same thing, we're telling them to go home and quarantine. So stay in your home, or if you're staying downtown, you stay put, don't interact with anyone that you're not normally interacting with. We're not routinely checking antibodies on patients. We're doing part of a study for those that have been exposed or proven to be infected, as well as employees in the hospital. All of our staff are wearing masks, so everyone that we see in the hospital, we see in clinic, we see on the wards, we see in chemotherapy suites, we see in dialysis suites, we're all wearing masks. If the patient isn't wearing a mask, we're actually wearing eye protection now as well. We've been doing all of this probably for about 6 weeks, maybe 8 weeks. And we've actually found it to be very beneficial for the staff, but I also think it's beneficial for the patients we're seeing, especially those in clinic, because we're, by wearing that, protecting those patients. Those patients, by wearing a mask when we see them, are protecting us. So I think it ends up being that two-way street. And that's been the most effective process. And I think really being able to test everyone before these procedures, and then we test all new admits when they get admitted, no matter if they have symptoms or not, they're getting tested.
Andy, are we doing that as well now? All new admissions? I've seen some recent reports. Unmute. Unmute, Andy.
Sorry. So if they're coming in for a direct admission or coming through the ED, everybody's getting a COVID rapid test. So that's usually a 2 to 3 hour test until it comes back. If for whatever reason those reagents are not available, they get a standard RT-PCR test and go into a COVID room until they're proven negative. Mm-hmm. We are using the same policy that Mike mentions from Northwestern, where all staff are wearing a mask as well as face shield or eye shield.
We're all wearing face shields, yes.
Whether it's outpatient evaluation, seeing a patient, or an inpatient visit with a patient.
Marina, what's the policy in Milan when you're either in clinic or in the hospital?
So it's you can't come to the hospital without wearing the mask, and for the surgery and also for all the treatments, you have to prove a negative test 48 hours before the treatment or the procedures. And during the 48 hours, you must stay at home very protected. Mm-hmm. All the doctors are tested not so often, just every month. So this is, I think that we have some concern on that. And in the entrance of the hospital, you can't come in the hospital if you have a fever. So, because we see that there are some results saying that maybe the most contagious people are the symptomatic people. So, if you have a fever, you go in you go directly to the test, and if you are positive, you go in a COVID center. So, we try to keep as clean as possible our hospital, to continue to treat all the patients as much as possible. For the surgery, what we do is we do a CT scan, because sometimes we feel that the CT scan is more sensitive also compared to the test. So if you have a CT scan which is suggestive because you have patches or you have some areas suggestive, you go to the test, and you can have access to the surgery only if you are negative 100%. So in this way, we are able to do 90% of the surgery as before.
Roy, I assume something very similar, similar strategy exists at Yale?
Yes, for procedures and for surgeries, we're testing. One thing we're not doing is we're not testing people before they start chemotherapy. We're actually, in our lung map study, which, I'm very involved with, we're beginning to ask sites around the country what they're doing. I think there's a lot of variability, but, we are just going based on travel history and symptoms and exposure and so forth. And one of the concerns I have is the test is not 100% sensitive. So we still, are not testing routinely for other cancer patients.
Nor are we before immunotherapy chemotherapy unless they're manifesting symptoms. Marina, early on, I think you had a hub and spoke approach where you, very similar to what Roy has done, you sort of separate the COVID positive from COVID negative patients. Are you reintegrating now, or is it still very separate?
No, we continue to have totally separate pathways for these patients, and we try to maintain as clean as possible the oncological parts to continue to deliver treatments in the most safe place. So there is a COVID positive and COVID negatives in all my cities. So there are hospitals totally dedicated to COVID positive, and the cancer centers are totally dedicated to the cure of cancer patients. And I think that I agree with Roy that maybe you don't have 100%, but for example, in my city where we had so many cases, if you test before and you have a high incidence in the city, you are able to remove the positive patients to the COVID center. So if you are in a city where the incidence is not so high, I don't think that it's necessary to test these patients. But if you are in Milano, maybe yes.
Yeah. Andy, we've certainly not created separate COVID positive, COVID negative hospitals. One of our associated institutions, not with Penn per se, but in Philadelphia, Fox Chase actually became the COVID negative hospital and started to accept non-cancer patients, whereas Temple is the COVID positive. But we've actually managed to cordon off the outpatient department from inpatient and create separate COVID positive units. Has that worked out okay in that regard?
Certainly in the inpatient setting, they created COVID positive units. And so units before that were general med surg units or general ICUs, those became isolated COVID units. And if they were not, it was actually a pretty remarkable facilities process to take med surg regular floor beds and convert those into negative pressure rooms. And so there was a big effort to do that. And there were 3 floors in one of our unit hospital towers that they converted into all negative pressure rooms for the COVID positive patients. And then converting some of the ICUs as well that were surgical ICUs that weren't necessarily negative pressure, converting all those into negative pressure rooms. So on the inpatient side, they certainly created one tower, more or less, that had all the COVID positive patients, and all the COVID negative patients were in the other bed towers. So on the inpatient side, it was effectively isolated as best we could. On the outpatient side, as you said, we have not separated those out, just taking the normal screening procedures at the door upon entry, and then triaging accordingly there if they were symptomatic.
All patients and frankly caregivers get temperature tested, and then masking tape with their temperature on their clothes, and there's a Purell container greeting them at the door. And even amongst the staff, me included, the attendings were not permitted to visit their inpatients, their patients while on the inpatient wing during the height of the crisis. That has finally changed a bit. I want to get back to lung cancer specifically and to immunotherapy, Marina and Roy. Marina, how it sounds like you have now resumed giving patients who qualify for checkpoint inhibition their therapy. Are you making allowances in terms of the schedule going 4 weeks or 6 weeks? How are you approaching this?
Yeah, we moved to schedules with 6 weeks, but not because we feel that these patients are in danger for the immunotherapy, but just for reduce the visits to the hospitals. So although if we are trying to create a protect place, it is still a hospital. So the possibility to find the COVID positive in the same hospital is higher compared to, so we believe that to use 6 weeks is better just because you avoid visits to the hospitals. But now, after 4 months, we believe that there is no detrimental effect if you treat patients with immunotherapy. So we are less scared than in the beginning. In March, we were very scary that treating these patients with immunotherapy for the cytokine storms could create a COVID positive, a more severe COVID. Now we are more confident that the only problem is coming to the hospital so often.
Roy, same question. You pretty much maintain immunotherapy right along?
We did, and we have a protocol where we're collecting samples on patients getting immunotherapy, because you might think that the immunotherapy could even help, patients clear the virus early on. But I agree with Marina that the in the end stage where they have the cytokine storm, and you worry that the immunotherapy might accelerate some of that inflammation that we see. But as I said, we haven't had that many patients. We opened up this protocol and we started collecting, and we've really, we've started to even, we actually even have a special COVID emergency room for cancer patients. So we have taken our, we a couple of years ago, we made a special emergency center for the cancer patients. So now we've divided it in half, and anyone in whom we suspect COVID, we do the 2-hour rapid test. So we're trying to really keep as much of the virus off of our inpatient floors as we can. Not perfect, but we're trying, and so far it's been pretty good.
Have you you mentioned the Q6-week regimen? Do you do that right off the bat, or do you wait until patients have been on Pembro or similar immunotherapy agents for 6 months or a year?
Well, for the 6 months and a year for sure, and then we're doing telehealth visits in between. In fact, I worry we're doing almost too many telehealth visits. I think we need to get the patients back, because part of the multimodality care is everyone working together and having your social work and your pain team, and we don't have that now. But yeah, if it were a new start and I could give immunotherapy alone, I probably would do every 6 weeks.
Really?
And try to lengthen out the visits. And avoid chemotherapy. But now we're getting a little, our infusion centers, I don't know about yours, Corey, they're pretty busy. In fact, we have less space because, again, we've moved out. We had the same thing as you had at Penn. They, our new cancer hospital was built right after SARS, so the floors were all negative pressure. So we did the negative pressure switch, and we moved all the cancer out of that hospital. And we're using space now. We're borrowed space from endoscopy and other groups to do our infusions, but it's full. The cancer patients can't avoid getting treated, but when we can, we're trying to minimize the amount of chemotherapy we give.
So what we've done, at least with immunotherapy, we're variable. For starts, we've been doing 4 weeks, and then in patients have been on maintenance therapy for a while, clearly doing well. We started to stretch out to 6 weeks. Remember, this was based on, I know there's an approval, but it's based strictly on pharmacokinetic data and not on real clinical data, which always makes me a little bit nervous. Marina, you mentioned TKIs, that there was some concern early on, but much less so now. You've continued, you haven't paused patients receiving targeted therapy, have you?
Yeah, so we are now 4 months from the beginning. So we treated also some patients who are still COVID positive. For example, in the beginning, we had patients on alectinib. We stopped alectinib, and we started again alectinib when the patients were still positive with the swab. So now we believe that if you are on tyrosine kinase inhibitors, is not a big problem. Maybe we don't know if this is an effect of the treatment, or if it is just because these patients are younger and without so much comorbidities. But we are now quite flexible with tyrosine kinase inhibitors. And after 4 months, we had to restart some treatments, although if they were still positive. Because what it is very strange is that sometimes the swab remains positive for a very long time. So we had patients with the swab positive for more than 2 months. And with lung cancer, you can't avoid to treat the patients for a long time. So we had to take some decisions to restart the treatments when the virus was potentially still present. So what we are doing now is to wait that the patients become totally asymptomatic and we restart the treatment. Clearly not chemotherapy.
So chemotherapy has remained on hold. What about your clinical trials? Did you pause all of them, or are you able to continue some of those?
So what we did in the beginning is to avoid, so some companies closed the clinical trials, as you know, and we tried to avoid to include the patients in the clinical trial when there was a placebo arm. So we felt that it was not ethical to make the patients in the hospital with a placebo, with a potential placebo. So we closed all these treatments, and now we are restarting in a normal situation. Although the virus is still present in my city with less cases compared with the beginning, but I believe that we have to move from the idea to live without the virus to live with the virus. So we have to find a balance and to live with the virus and to try to avoid to have the virus in the hospital and to have the virus among the healthcare workers and to avoid the spread. But it is clear that in lung cancer, we have to continue to treat these patients.
Mike, how do we live with the virus? I think we all had this probably benighted hope that somehow miraculously it might disappear, but it's obviously not going to do that until we have a vaccine or until we probably have more generalized testing, uniform testing that we can isolate people more readily. So from the standpoint, I'm sure you must deal with this in ID protocols, but as a thoracic specialist, how do we safely live with the virus? And is there anything, there's been some speculation about renin, angiotensin, specific pathways that might exist between the virus and lung cancer. Anything unique about the pathophysiology in the lung cancer setting?
Yeah, so I think that's a great question. You know, how do we all live with this virus? Because I think we have to. I think it's not going to go away until, you know, we do get a vaccine and we do have more positive serology throughout the community, and we know that it's protective. And so I think the way that we start living with the virus is we start adapting a lot of the processes that we have had in place during the surges. We just have to pull back on them a little bit. So I think wearing the mask, so I think that becomes part of our regular routine. I think asking patients about their symptoms, that becomes part of our regular routine. Maybe putting these tests, putting the SARS coronavirus 2 PCR on our test for all the other respiratory viruses. So when we're looking for influenza, we're also looking for SARS-CoV-2.
Yeah.
And so, you know, this way we can start identifying those cases earlier. We can start picking them up earlier. And then with the masking and some of the distancing that we're doing, we're providing that kind of extra protective layer. In terms of some of the pathophysiology, I think that is evolving. We know that the coronaviruses, when we go back to SARS-CoV-1 and MERS and some of the other animal models with the mammalian coronaviruses, there's a plethora of physiology that goes into this hyperimmune response and this hyperinflammatory response. The SARS-CoV-1, SARS-CoV-2 are unique in that they are binding to this ACE inhibitor. That's their binding site to get into our cells. And how that is activating and changing our response or the virus's response to that entire system, we don't really fully know. Early on, there was all the, you know, people on ACE inhibitors or on angiotensin receptor blockers might be more at risk, less at risk, who knows what the risk. And I think right now it's a little bit too premature for us to know fully what that response is going to be. I think that's where we hope a lot of the research that's going into this will identify that. We have not been recommending, for instance, people stopping their ACE inhibitor or their angiotensin receptor blocker agents. We tell them to keep taking it. We haven't said, no, you need to stop because of that risk. We have modified not being an oncologist, but working with our oncologist, we have modified a lot of our chemotherapy protocols, similar to what everyone on the panel has been talking about, where either extending the interval of time that people are getting the chemotherapy. We've started to put back some of these more immune therapy because maybe those are less of a problem in individuals with cancer and the coronavirus. Whether it's the cell cycle inhibitors or PD-1s or the tyrosine kinase inhibitors, they may not be as bad as we thought they were, and chemotherapy itself may actually be worse for some of these patients, and they may get sicker on the standard chemotherapy, but not on some of these newer agents. And so I think we've been adopting exactly what everyone on the panel has been. But I think really we have to live with this virus. I think it's going to change all of our practice, more televisits, kind of more hoops for our patients and us to go through to get in and out of clinic and to see patients until we know that we've started to push this virus away a little bit more.
So I want to give everybody a minute or two for some closing comments. We'll start off with you, Roy. Your perspective on all of this, how it's altered not just the lives of your patients and staff, but your own life.
Right. This has been something that, no one's ever lived through, thank goodness, before. It's been hard. I think I'm concerned about patients and maintaining patient care. I worry about all those undiagnosed lung cancer patients who are out there right now, who are going to come in with more advanced disease because, we haven't diagnosed them early enough. Our surgeons are finally getting back to work, and our pulmonologists and so forth. I think we do need to treat patients with the immunotherapy, the chemotherapy, and I'm glad that's getting back. But I worry about the protocols. Many of these protocols, especially phase 1, how often in lung cancer do we use phase 1 protocols? And 5 years ago, 6 years ago, that was the PD-L1 and the PD-1 protocols. All those are halted. So there are many patients who aren't getting therapy. There are many patients who aren't coming in, and they're coming in late. I've seen that a number of times. People who come in late, and they're more sick because they haven't come in. So it certainly has been a problem. The protocol research is halted, as I mentioned. So, but we're managing as best we can. We have to learn a little bit more about how these therapies react with the virus, especially the inflammation that the virus causes. And we tried to collect as many samples as we could. And now that the virus numbers have died down, it's hard to get enough samples. But we're ready. If there is another wave, we have all of our people in place. But we have enough samples. We're doing a lot of screening, healthcare workers, screening the healthcare workers. We're doing antibody tests here at Yale. I think they've tested several thousand healthcare workers, and people who have been exposed. Very few people actually show exposure. Very few doctors, thank goodness, have been positive, in large part because we learned from Marina and Italy and other areas, and we had more PPE. But it's certainly been a challenge, and it's pulled the team together. I think when this is over, we'll be a stronger unit because
I hope so.
we're working as a team.
Mike, your comments?
I think my hope is that we all learn from what we've all experienced. I think it's really going to make us all work together more effectively. I think that's, to me, the biggest outcome from the pandemic. We've all learned to work in unique ways. We've all learned to work in different ways. But I think at the same time, we've all learned to work together in a way that I think is really unique, not just physicians or oncologists or pulmonologists or infectious disease specialists, but relying on all the other members of the care team and how everyone can kind of impact the care of our patients. And then I really hope that what we've learned from this part of the pandemic, when we see this virus again, we're able to, I think, much more quickly respond. And so we don't have the problems that were faced in Italy, that Marina faced in Italy, that we don't have the problems that we're seeing in New York, that we can kind of get ahead of the game and really start pushing against the virus and providing the right care for our patients, and then not letting people fall through the cracks. We could still do that usual care as well as the pandemic care.
Andy?
So I think I'll agree with what the other panelists have said, that this is a disease that we're going to have to learn to live with as opposed to solving completely. I think one of the biggest things we can work on going forward is more testing and contact tracing. I think that's the way that we're going to minimize disease spread and subsequent surges. And I think certainly in the United States, I don't know about other countries, but we are lagging behind in our abilities to contact trace and make this a laudable goal going forward. The thing that's really amazed me is, and Mike mentioned this a little bit, is how fast and rapidly the healthcare system rallied in the United States, from an infrastructure perspective to building these units, to taking care of the patients, to ramping up clinical trials and enrollment in trials to get to data to really guide exactly how we can manage these patients in the best way without harming them with some of these treatments that seem to potentially be harmful. So I think a major impact that I have just globally on the world is, especially in our younger population, is the social and emotional impact this is going to have on them. This has had a major impact on my son and his ability to cope with not seeing his friends, not being in school. And so I think we really have to think about, as a healthcare system, how we can address these concerns going forward and help these children.
Marina, you have the last word before I conclude.
Yes, I echo what all the others said. So I think that it was amazing how we were all together, to trying to be connected, to share experiences, to share research, and to stay in a team like an orchestra and not just like different teams in the hospital. This was very amazing. In my country, which is not very digitalized, we started to do the telemedicine, which is a novelty, because in Italy, you know, the people want to see each other. There is a lot of social environment. So for our culture, it was very difficult to use the telemedicine and to place social distances. But we felt that we can stay together also with the distances. So I think that we still have a lot of things to learn, because maybe we don't know if the patients asymptomatic are really contagious. So we don't know many things. So I'm sure that if there will be a second wave, a second peak, we will be much more prepared than this time. But we have also the awareness that we are all together.
I really appreciate those thoughts. I agree with them all. My two comments: I think this is going to lead to a major emphasis on public health that really had completely fallen by the wayside up until the time of the pandemic, that we're going to get creative about this, that we're going to finally, hopefully, learn to be together and not we keep talking about social distancing. I prefer the term physical distancing, because the social aspects should not be sacrificed. And as you point out, it's very hard to interact with our patients across a video screen, but at least for the time being, it's necessary. As for research, I think we've learned a lot as well, that there's a lot of gratuitous, unnecessary clinic visits that we can probably safely part with, additional testing that really doesn't work toward the integrity of the protocol or to the safety of the particular agents. And I think clinical research will also be altered permanently by this pandemic, and hopefully will come out for the better. So with that, I want to thank you for joining us for this program today. If you have any questions, please submit them in the Submit a Question tab located in the right-hand navigation bar. One of our expert faculty will, I promise, respond to your query. To receive your CE credit for today's program, please complete the evaluation located on the right-hand navigation bar. You will then be able to download or print your certificate. And please join us next week when we launch Module 2 of the series. Thank you again for joining, and thank you very much for my participants, Dr. Haas, Dr. Herbst, Dr. Garassino, and Dr. Angarone. You've been phenomenal. Thank you, one and all.